Now it's my great pleasure to introduce Curtis Barnett, the President and CEO of Arkansas Blue Cross Blue Shield, a nonprofit mutual insurance company which is the largest health insurer in the state of Arkansas with about 2 million members. And Curtis is really a champion for improving the health of his fellow citizens in Arkansas, the most vulnerable people there, the most vulnerable populations. And under his leadership, the Arkansas Blue Cross Blue Shield has instituted a number of programs around opioid addiction, health literacy, and even food scarcity. But he's here to talk about one of his really key components to his vision of making healthcare more accessible and affordable. And that's a movement to alternative care models in collaboration with the state and federal governments. And they've had a remarkable amount of success in Arkansas, and it's really served as a model for CMS and for other states. As you can hear today, Curtis is pretty passionate about building a better healthcare system, and we're really pleased to have him with us today. Thank you, Curtis.
Thank you, Nancy, and I think it's very fitting for me to follow Michael in our comments today because Michael spent a considerable amount of time in my home state studying the effects of many of the initiatives that I'm going to be talking with you about this afternoon. When I joined Arkansas Blue Cross and Blue Shield in 1993, I worked with a product called the Primary Care Network. That was a product that we made available to large employers and located in rural parts of our state. These were communities with populations as small as 3,000 to as large as 20,000. They're communities that had primary care physician clinics and at least one large employer, sometimes more, and these tended to be Fortune 500 companies with a plant or a mill located in Arkansas. These were gatekeeper-type models so that care for the employees and for their family members were directed to the primary care physicians, and those physicians treated those patients as well as coordinated their care and then referred them for any additional services. The physicians were under financial risk for how the plans performed, and one of my main jobs was to work together on a regular basis with employer leadership and physician leadership to bring them together to manage those programs. And we would go through extensive data analysis to do that. And you can imagine in 1993, these were mounds of data and mounds of reports that we would work our ways through. But what we were trying to do in that setting is to look at which primary care physicians were performing the best, which are the most effective and efficient hospitals and specialists for them to refer care to. And we were aligned together to manage those healthcare costs because we all had an interest in keeping those jobs in those local communities. And we were really trying to work toward two objectives. One was to establish the primary care physician as the care coordinator, and then the second was to identify and reward value. Now, fast forward 24 years, and while we do not continue to have that particular product in our state, as an industry, we continue to work toward those objectives today. It's what consumes us almost on a day in and day out basis. And I would say that over that 24 years, we have seen progress toward those two objectives, and especially in the last 5 or 6 years. And some of that, and I think a big part of that is that we've had a new partner involved with us as we pursued those objectives, and that partner has been the public sector. So what I want to do today is just kind of give you a look at what public and private collaboration has looked like in the state of Arkansas. I want to go over the initiatives that we've pursued, talk about some of the support that's needed to make them work, and then just end by talking a little bit about really how all of this work has influenced our view and our approach to driving the healthcare system toward value going forward. The healthcare challenges in Arkansas are not different or too different than those you see in other rural states, especially southern rural states. It's hard to navigate, it's fragmented, there's very little visibility across the spectrum of care when you're thinking about quality and you're thinking about cost. Healthcare spending is growing. It's growing at rates that it's severely straining the public and private payers in our states. And the health status of Arkansans tends to be relatively poor. We rank at or near the bottom in a number of key health measures, whether it be obesity, type 2 diabetes, preventable hospitalizations, prenatal care, or smoking. We tend to rank toward the bottom. But by working together, public and private sectors have begun to transform the healthcare system in the state of Arkansas. This is the framework for how we've been going about that work, and it's called the Arkansas Payment Improvement Initiative. And there are two main components to this. The first is a patient-centered medical home model that we've had in place, a pilot with our program, with our company going back to 2010, and it ties directly into the Comprehensive Primary Care Initiative that's sponsored by the federal government. And then an episodes of care component, which we put in place in 2012. And then all of this work was helped tremendously in 2013 when our state received a State Innovation Model Grant from CMS. I think it's important to note that Arkansas Payment Improvement Initiative is not just a public-private collaboration. It truly is a multi-payer initiative. As you can see, all the major private payers in our state are involved in this program at some level and have been supportive, as well as major employer groups. Large self-funded employers who have a commitment toward value-based care have been partners in this as well. I want to start by talking just a little bit about our patient-centered medical home approach. These are the objectives of a well-designed patient-centered medical home. To achieve these objectives, a practice has to go through significant transformation. For example, they must commit to a team approach to care. They must identify their top 10% priority patients, have care plans, use electronic health records, arrange for 24/7 live access to care going forward. So all of these are important activities that they have to undertake in order to transform their practices to be patient-centered medical homes. In return, these practices do receive upfront payments which help fund those transformation activities. In 2010, our company put a stake in the ground, and we said that if we're going to have a sustainable healthcare system going forward, we've got to have a strong primary care infrastructure. So we embarked upon what turned out to be a 2-year pilot program to see if we could transform primary care physician practices into patient-centered medical homes and assist in that process. And these are the goals that we sought to achieve. In only 2 years, we did see some very good results. We saw hospital readmission rates for those patients who were attributed to a patient-centered medical home go down. We saw emergency room visits and emergency room-related costs go down as well. We saw the appropriate use of the emergency room actually go up, as well as generic drug prescribing rates. But we also came away from this pilot with some very significant and valuable lessons learned. And probably chief among those is the need for payer alignment when you're pursuing these types of initiatives. Even with our market share, and we tend to be the market share leader in the state of Arkansas, we realized very quickly that any one private payer would not represent enough volume to get the practices to make the investments that were needed to transform their practices the way that they needed to be that they needed to occur. So we understood that very quickly, that without much more volume, this tended to be a one-off effort and would have a very short shelf life. And so you can also see we had other important lessons learned as well. So in 2012, when CMS opened up the opportunity for markets to apply for the Comprehensive Primary Care Program, or CPC, we took our lessons learned. We joined with Arkansas Medicaid and our state's Surgeon General and other healthcare and political leaders in our state, and we made application, and we seized that opportunity at that time. You can see in the period from 2012 to 2016, we were one of 7 markets that were selected. We were one of 4 that were statewide. We had 68 practices that were selected, 268 providers, and 5 payers participated, including Arkansas Medicaid. And again, that was critical to having the patient volumes that were needed, because now we not only had the patient volume, but we could offer the incentives necessary that would be sufficient enough for these primary care practices to make investments in infrastructure and changes in their clinical decision-making and operational processes that were needed to transform their clinics. The volumes were absolutely critical to doing that. Over the course of the time period that we participated in the CPC and what is now called the CPC Classic program, you can see that, we did participate throughout that time period. We saw improvements in patient satisfaction and experience of care. During that time period, we saw reductions in hospital admission rates by those patients who were part of the patient-centered medical home programs of 15%, which led the country. We saw reductions in emergency room utilization as well. We saw improvements in quality metrics and the information that was captured there. And then Arkansas in 2015 and 2016 did have net savings as a result of this program. So we came away feeling like it was a very, very much a success. The experience that we had in CPC Classic program led us to want to pursue to be part of the CPC Plus program, which went into effect January 1 of 2017. So we're a part of that as well. We're one of 14 regions around the country that have been selected for CPC Plus, and you can see that we've grown our participation across the board. We have 182 practices now, who are now part of that, 689 providers, and we're up to 7 payers who are supporting this initiative. That's important as well, because we think this will allow us to have a much greater impact going forward. I now want to turn my attention and talk just a little bit about the Episodes of Care program. We worked very closely with Arkansas Medicaid to basically develop and implement the Episodes of Care program. The purpose of this program was to improve quality and to basically reduce the variation in the types of procedures that were used to treat acute conditions. And so we felt like it was a very important movement in the right direction. For each of the episodes, a clinical leader is identified, which is called the principal accountable provider. And so that individual is identified. There are quality standards that were established, and then there were thresholds also established, which laid out the commendable, acceptable, and unacceptable cost levels for each of those episodes. And then we also provide regular reporting back to the clinical lead so they can look at the episodes across the entire spectrum of care and look at not only how the quality measures are performing, but also the utilization and aggregate cost associated with those different episodes. To date, we have 22 episodes of care. Each of the payers is free to decide which of the episodes they want to implement based upon the populations that they serve. For Arkansas Blue Cross, we've implemented 14 episodes of care. This is an example of how the payment model works for the Episodes of Care program, and you can see that at the end of the performance period, an average cost per episode is calculated for each of the clinical leads. This is usually at the end of a one-year period of time, and that there are commendable levels, acceptable and unacceptable levels. Those who perform and meet the commendable level do qualify for gain sharing, and so that is shared back with those particular clinical leads. And those who perform above the unacceptable level have to share in the cost of that program. So a portion of their payment is then recouped as a result of that. Since putting the program in place, we have seen what the intended effects were meant to be, which is we've seen variation reduced, we've seen quality improved. And so we feel like this has been an important movement in our state. These are some high-level results from a couple of the episodes that we've had in place, probably the longest for our state, or at least for our plan. The perinatal, you can see quality up, cost down, and then also total knee hip replacement. Now, I do want to point out that these cost reductions are not adjusted in any way for inflation. So if you were to do that, assuming that the cost would be growing year over year just due to inflationary factors, then I think the cost reductions would have an even greater impact. And then I did mention this earlier, but Arkansas was one of several states who have been selected for a state innovation model grant. Our state did receive a grant of $42 million to help fund the Arkansas Payment Improvement Initiative, the activities that I've been talking about, and help develop those episodes, help develop our patient-centered medical home process. And we think that that partnership with CMS as part of this is certainly indicative of how public and private organizations should work together. So as you can see, we've been having an impact in our state. But I don't think I can overemphasize the importance of data and communications when supporting these types of programs. When we implemented these programs, we rolled them out. We worked very closely with Arkansas Medicaid, especially on the Episodes program. And we held 21 public work group meetings in 8 locations around our state. And we received feedback from over 500 providers, patients, and other stakeholders who helped really shape how these new models would look and how they would work. Ongoing communication is absolutely critical as well. We have teams, each of the payers have teams who are involved in this on a regular basis. So we have weekly, we have monthly, we have quarterly meetings. And it's not just the payers who are getting together to work on the program. We're also including, in many cases, the Arkansas Hospital Association, the Arkansas Medical Society, as well as the practicing physician, the participating practices as well. And what we're doing in those sessions, we're sharing challenges, we're talking about program changes, and as much as anything, we're talking about best practices. Data is also absolutely critical to the success of these programs. We decided early on that if we were to try to build whole new technology tools from scratch, they would add tremendous cost to this. So Arkansas Blue Cross made available our Advanced Health Information Network very early on in this program. And so it was already being used by 99% of providers in Arkansas. So it already had a presence in those offices. So we were able to use that as really the way to push information and data out to all these provider practices, and especially all the reporting. We think that was absolutely critical to keep the providers from having to log into multiple systems and to learn multiple report formats to get them to feel much more comfortable with the program. We provide a variety of dashboards to our participating practices as part of this initiative. There's drill-down capabilities that they can see exactly how they are performing and where there are potential areas for improvement. One of the things that we did early on also is we established a dedicated resource center that providers could contact and that we would also outreach to them to help them understand the reporting and help them understand how to use that information to help drive practice improvement. So I want to end by really going back to my comments at the outset. I feel like we've made in our state very good progress at those objectives that I talked about, and that is to improve care coordination and to identify and reward value. We think a lot of that progress has really occurred as a result of our collaboration between the public and private sectors. By having Arkansas Medicaid, by working with CMS, we've been able to bring together a much bigger impact than we could have before. At Arkansas Blue Cross, we're convinced that we need to continue to move this market toward value-based payment. And we think that's absolutely critical to having a sustainable healthcare system going forward. And we also believe that all the initiatives that we've worked on, that I've spent the last few minutes talking about, some ACO-like models that we've worked with providers on in our state called collaborative health initiatives, we feel like all of those different efforts have really helped lay a foundation that we can continue to pursue this going forward, and we're working on those plans today. But we also want to continue to collaborate with public programs, and I encourage public agencies, whether it be state or at the federal level, to continue to view the private payers as partners in innovation. We think that's absolutely critical as well. And finally, just leave you with one other remark, and that is that we have seen firsthand in our state that by working better together, by combining our patient volumes, by combining our different perspectives, by combining our different areas of expertise, by combining our resources, that we can pursue common strategies that can be scaled to address common challenges. And we believe that by working better together, that we can have a much greater impact than any one company or any one agency can have working alone. Thank you.